Today we're going to talk about Kawasaki disease. It is a type of vasculitis, meaning it is an inflammation of the blood vessels. It affects medium-sized arteries and predominantly appears in children younger than 5 years of age. In about 80% of cases, the incidence is highest among children of Asian descent, but it is seen worldwide. The etiology is still unknown. It is possibly due to an exaggerated immune response to an infection. There are quite a few theories out there, but don't waste your precious brain space on this. Let's focus on learning how to diagnose and treat it. The disease was discovered in 1967 by a Japanese pediatrician, Dr. Tomosaku Kawasaki. Dr. Kawasaki was working in a Tokyo hospital in the early 1960s when he examined a little boy who had a high fever, red eyes, and a red rash, among other symptoms. He first thought the child had scarlet fever, but a negative throat culture ruled that out. The next year, 6 more children turned up at the hospital with the same symptoms, leaving Dr. Kawasaki puzzled. So he started collecting and publishing those cases, and after a few years he even came up with the name for this new disease. He called it mucocutaneous lymph node syndrome, but fortunately for all of us that have to learn it, Kawasaki disease is the name that stuck. Disease is typically a self-limited condition, presenting with fever and erythema, another word for redness, and lasting for an average of 12 days without therapy. However, if left untreated, serious complications can develop, such as coronary artery aneurysm, arrhythmias, and heart failure, thus making it one of the most common causes of acquired heart disease in children. Clinical Pearl Alert. Please remember that the most important complication and cause of death in Kawasaki disease is a coronary artery aneurysm. That is why early recognition and initiation of therapy are essential to prevent potential coronary complications. So how exactly do we diagnose it? Well, we use the official criteria, and these criteria say that the child has to have a fever for at least 5 days, combined with 4 or more of the following 5 physical findings. Number 1 is bilateral conjunctival injection, or red eyes for short, usually without discharge. Number 2 is a polymorphous rash. Number 3 is erythema of the palms or soles and edema of the hands or feet in the acute stage. In a later stage, also called the convalescent phase, you will see skin peeling off on the fingers and toes. The 4th condition is cervical lymphadenopathy, which is usually unilateral and has at least one lymph node bigger than 1.5 centimeters in diameter. And last but not least, oral mucous membrane changes, including red cracked lips, pharyngeal erythema, or strawberry tongue. I know this is all a bit too much to remember all at once, so here is a nice acronym for you. What do you get when you take the first letter in conjunctivitis, rash, erythema, adenopathy, and mucous membranes? You get cream. And that's it for this panel. Wait, we have another Pearl Alert. Let's switch panels for a moment. Diagnosing Kawasaki disease can be difficult in the first few days of the illness when only a few classical findings are present. Also, a lot of the time, symptoms don't appear at the same time, which is why ongoing follow-ups are essential. If less than 4 findings are present, the child might have an incomplete form of disease. Incomplete disease occurs most frequently in infants, who are unfortunately more likely to develop coronary complications. Since we don't live in a cartoon, here are a few real-life photos so you can more easily recognize patients with Kawasaki in your clinical practice. I hope these criteria are pretty clear by now. Also, a good thing to remember is that fever is minimally responsive to medication and typically remains high. By using the aforementioned criteria and lab tests, you will be able to make a diagnosis. Lab workup will show elevated red blood cell sedimentation rate and markers of inflammation, normocytokine, leukocytosis, thrombocytosis, low albumin levels, and elevated liver enzymes. After diagnosis, heart ultrasound should be performed as well as 6 to 8 weeks later to check for signs of myocardial damage and coronary aneurysm. The differential diagnosis of Kawasaki disease includes some bacterial diseases like streptococcal infection of the pharynx, which typically does not have conjunctivitis, and scarlet fever, which has a sandpaper texture with accentuation in flexural creases, so-called pastia lines. Prominent features of Rocky Mountain spotted fever and leptospirosis are headache and gastrointestinal complaints. Another option are various viral illnesses such as measles, varicella, and DBV. Measles have an accompanying enanthema called Koplik spots and rash that tend to occur on the head and then migrate to the trunk. Varicella has a vesicular rash, and exudative tonsillitis can help you distinguish EBV infection. Other causes include drug hypersensitivities and systemic onset juvenile idiopathic arthritis. I'll go through all of these in separate videos, but it is useful to have a few diagnoses in mind when dealing with these types of clinical cases. Treatment includes intravenous immunoglobulins, given as a single infusion, and high-dose aspirin. It's important to start the therapy before the 10th day of illness because aneurysm rarely forms before then. This is one of the few conditions where we are not afraid to give the child aspirin in fear of Ray's syndrome. Aspirin is continued until lab markers of ongoing inflammation return to normal, unless coronary artery abnormalities are detected by echocardiography, in which case aspirin therapy is continued. Without treatment, up to 25% of children develop coronary artery aneurysms, while only a couple of percent do so. Even with treatment, aneurysms can develop at other sites like the brachial, axillary, femoral, and renal arteries. Death is rare and is caused by sustained heart damage and aneurysmal rupture. Thank you for watching this lesson. If you liked the video or learned anything, please consider subscribing because I'll be making more soon. Also, any new video ideas are welcome in the comments. See you in the next video.